The term OCD gets thrown around a lot these days, and if you find yourself wondering what exactly OCD is, then you're in the right place, because in this episode of the Mental Health Toolbox, we're talking all about obsessive compulsive disorder with special guest Andrew Cohen, OCD and Anxiety Specialist. Andrew has a thriving private practice in Westlake Village, California. And in case you didn't know, this is OCD Awareness Week.
Okay, so for the listeners, basically what ego dystonic means is these are thoughts that are not in line with your morals and values and who you are as a person. And OCD thoughts are ego dystonic, and that's what makes them so scary. Okay, and then ego syntonic are thoughts and things like that that are in line with our values, what we like. So an example I like to use is, I have two dogs that I absolutely love and a wife that I love. And, I don't have harm OCD, but somebody, with harm OCD would potentially experience thoughts of, stabbing their dog or strangling their dog. And what OCD does and why it's such a bully and just a really, really difficult thing to deal with is it attacks the things you love and it knows what's going to get under your skin.
Our guest this week, Andrew Cohen, has brought to my attention that there's a special 2-hour online virtual event in honor of OCD Awareness Week that's being held on October 15th, Saturday. If you would like to sign up for this virtual event, you can send an email to info@ocdsocal.org. That's info@ocdsocal.org, where you can sign up to get the link for this online free virtual event. You'll learn about exposure and response prevention, 101 for OCD, medications for OCD, maintaining motivation in OCD treatment, navigating the family accommodation trap with compassion and confidence, as well as treatment for kids with OCD and what is upcoming in this specialized field. All right, I'll make sure to put that link up in the show notes and description so you can jump in and get your registration set up for this special online event. But without further ado, let's jump in and chat with Andrew Cohen, OCD Specialist and Anxiety Specialist. Let's go. Hello, Andrew, and thank you so much for making time today to be on the Mental Health Toolbox video podcast. I really appreciate you jumping on here to share your words of wisdom around OCD and anxiety treatment. So thank you so much.
Yeah, absolutely. I'm really, really happy to be here and spread awareness and hopefully help some people.
Yes, that's the whole goal. I appreciate it. Raise mental health awareness, psychoeducation, actionable tips and information, right? Because we all want to live our best lives, and right, and any ammunition we can gain around what moves the needle, is awesome, right? So that's the goal.
Absolutely, absolutely.
So I invited you on. I sought you out, actually. I vetted you on LinkedIn, and I really appreciate you responding because I have a particular passion around anxiety treatment. And whether that's social anxiety or general anxiety, or in this case, OCD, not something I'm specialized in. So I invited you on to share your words of wisdom, your knowledge around this subject, because I do believe it gets rather convoluted sometimes. The terms we throw around, people will say, oh, I have OCD, or they don't really know what that means, or I have anxiety. But anxiety is just kind of a bucket that contains a lot of different things. And so I hope to really kind of unmuddy the waters a little bit here for our listeners or viewers around how we talk about anxiety, and maybe when we're educating our friends and family on what kind of anxiety we struggle with, maybe learning the terminology to communicate clarification around those things, or if we're looking for treatment, maybe what to gun for and that kind of thing.
Absolutely.
Before we jump in, if you could maybe share a little bit about who you are, where you come from, and what you do, I greatly appreciate it.
Sure. Yeah. So obviously, Andrew.
Yes.
Andrew. Let's see. I mean, I grew up in Southern California. I was born on the East Coast. We moved out here at a young age. So, and growing up, I definitely exhibited or showed symptoms of anxiety disorders. Mainly, I think like separation anxiety. Never really got officially diagnosed with anything like that. And then looking back now too, definitely kind of OCD things going on as well. Personally, growing up, I wouldn't say it was like insanely debilitating, but it definitely impacted me as a kid. I actually had a really difficult time, like sleepovers, staying away from home, those kinds of things. And then growing up, let's see, around high school, I actually started going to my own therapist for the first time, and that actually is kind of what sparked my interest in psychology, wanting to potentially become a therapist. And in addition to that, like another one of my huge passions is music. I've been playing guitar since I was like 8 years old, and
Awesome.
In bands and things like that, and wanted to potentially try and pursue a career down that path. And then the more I, kind of looked into that, I felt being a therapist was a better fit for myself, and kind of keeping the music as a hobby and just kind of playing for fun. And then let's see. So, when I was going to therapy, it was kind of traditional talk therapy for a long time. It was helpful for certain things, just kind of like family issues or friend related issues, interpersonal things like that. But, I never really saw much of an improvement in the anxiety symptoms, which is common when it comes to talk therapy. And I'll talk about that later on. And I went to Moore College. I was kind of like in and out of therapy with the same person, just like here and there. And then I went to UCLA, and when I was in my last quarter there, things got really hard and bad for me. That's when like a lot of the OCD anxiety symptoms like totally spiked. And let me just explain, like, I was definitely dealing with it and somehow managing with it. But then once it got to like that last quarter, it got very debilitating. And I graduated, which was good.
This was undergrad or graduate school?
Undergrad.
UCLA.
Yeah. So I graduated UCLA in 2015 for undergrad in psychology, and I was working as a ABA therapist for a bit, and it was just very difficult balancing that with kind of the OCD and the intense anxiety I was experiencing. I started going to like psychiatrists to try medications, and things were like kind of helping, but not so much. And then finally, I went to this therapist who recognized, I think you're actually dealing with like OCD. And she's like, I don't specialize in this, but like, let's get you to someone who, knows how to treat this. And so luckily I, I went to, it's called the OCD Center of Los Angeles. My therapist there was wonderful. Her name is Laura Yoakum. And, I just remember the intake session. We did the Y box, which is the Yale Brown Obsessive Compulsive Survey to assess for OCD. And I was like, oh my God, like everything on here basically just was like screaming like at me, like, wow, this makes so much sense. And so I would go, I think like 3 times a week, 3 times a week, like 2-hour sessions at a time for a very long, for a couple months of that intensive. Then we'd titrate down a bit. But through that is where I really found my passion. I knew I wanted to be a therapist, but then I really found my passion for treating OCD and anxiety disorders, because I didn't really realize that's what I was going through all this time. And, luckily I was introduced to what's called ERP, exposure and response prevention. I'll explain that in a bit. But basically, it's the evidence-based treatment for OCD and anxiety disorders at the moment. It was, it definitely saved my life. And that's not me being like overly dramatic. That was, it was at that point where I was miserable. So, I was just really grateful to finally get to a therapist who recognized what was going on And this is no like disrespect to my therapist growing up, because he's awesome, a great therapist. It's just, I think with OCD and anxiety, the reason I like to do things like this is because it's so misunderstood and misrepresented. I wasn't the, oh my God, the germaphobe or the neat freak or whatever all those terms are.
You didn't show up to
wife,
session with your latex gloves on, and
exactly. I mean, my wife can definitely attest to me not being a neat freak, and things like that. So it just didn't show up in that way. My main compulsions were a lot of mental compulsions that no one even saw. No one even realized what was going on up here. It was like I was running a marathon in my head every single day. And I was exhausted all the time, and just it was really hard. And that's not to say I still don't struggle with it, because we'll talk about like OCD is a it's not curable at the moment. There's no known cure for it. It's just highly treatable. You can get to a place where you're kind of like what we call like subclinical levels, where you don't necessarily fully meet criteria for it, but there's ebbs and flows, and definitely deal with little lapses here and there, which is very common with OCD and anxiety. But yeah, so that's trying to think. Oh, and then probably should talk about how I actually became a therapist. After,
I'm loving this. I really appreciate you sharing your backstory.
Yeah. Absolutely. So after graduating UCLA and doing the OCD treatment, I went to it's called Cal Lutheran University, CLU. It's in Thousand Oaks for my master's in marriage and family therapy. And I went into that knowing I wanted to specialize in OCD and anxiety. And it's funny. Like, I don't know about your experience in grad school, but about what you learned about OCD, or if it was probably just a half of a psychopathology class, and maybe hearing the term CBT, but probably never really exposure and response prevention or anything like that. Maybe a tidbit. So I had to seek out, specialized training and everything. Yes, I had my own personal experience with it, but that's not, that's not enough to become an actual, therapist for it. So working in a lot of different treatment centers and treatment programs and things like that, trying to find a place that actually does, OCD specialty treatment. And finally I did. It's a place called Renewed Freedom Center for over 2 years in West Los Angeles. Dr. Jenny Yip there. She's excellent. Great training. And, they have like personalized PHP and IOP programs, individualized, where, you get a lot of great experience working with some very intense cases, along with just outpatient level of care too. So, your weekly twice a week kind of sessions. And then now, since I want to say about a little over 2 years now, I've been in my own private practice as well in Westlake Village. So that's where I'm at now full time. And I'm also on the board of the treasurer of what's called OCD Southern California, which is an affiliate of the International OCD Foundation. And it's a wonderful nonprofit organization. We've spread awareness. Our main location is Southern California. I had a little OCD SoCal,
that's
squishy. Cool. And we put on awareness events, like a virtual conference every year, and an OCD awareness walk. And actually I don't actually know when this is going to be released, but October 15th we're doing a virtual awareness event for OCD Awareness Week, where there's some presentations and talks on it. So I try to do as much as I can to spread awareness. And
is that a free event you guys are hosting?
Yes. So it's October 15th. I want to say it starts like 11 to 2. I can send you over the information.
Yeah, I'll put it up on the blog, the show notes, for anybody who wants to sign up for that, register. That'd be great.
It's a really special event. And I think, so that's kind of where I'm at now. I mean, I know I've been talking for probably 10 minutes, but
no, it's fantastic. I mean, it makes great sense. When I invited you on, I did not know that you had personal experience and dealing with this type of anxiety. And that makes sense. A lot of therapists, I think, gravitate toward their own pain points, right? Where they've had to overcome lived experience, right? Mine being like social anxiety to some extent. And Yeah.
And now look at you. You're hosting a blog
I
on
know,
YouTube.
right? How about that? I was always a behind the scenes guy,
Yeah.
and put me in front of an audience because I would freeze. But yeah, I think the reason I've sought out this kind of thing is because I have had to work very hard at things like public speaking, having the spotlight on me to some extent. And so this is kind of like my own therapy to some extent, even as
I mean,
even
this
as a
is
40-year-old man.
exposure therapy right here.
Yeah. Yeah. I think it keeps me in that mindset, to not shy away to some extent. So yeah, I mean, so you started off even interning ABA, right? Which is applied behavioral analysis. So we're talking about working with kids, I imagine.
Yeah, kids on the spectrum, along with some other, developmental disabilities, and with autism comes a high comorbidity with OCD.
That's what I was thinking.
And it's interesting because it wasn't really talked about much. But a lot of the ABA principles, it's very behavioral, and as is exposure and response prevention therapy. So it was a really good foundation, learning all of those kind of concepts.
Now, that was happenstance, or you sought that out?
I'm sorry?
Was that internship happenstance, like just the first one you're able to snag, or is that something you sought out?
So that's actually something I did seek out. Growing up too, I like would I wouldn't say intern, not like intern in the sense of like accruing hours, but like just like when I was in undergrad, I would like over summers do little internships or like work at these camps for kids on the spectrum or who have disabilities. And, I knew that ABA is one of the only jobs you can get to be in the psychology field as an undergrad, at least right off the bat. I mean, you can work in like residential treatment centers and things like that as like clinical assistants, but I actually didn't even know about that part until now. But yeah, I did actively seek it out. Worked for this place called First Steps for Kids. And it's really hard. Probably the hardest job I've ever actually had.
Imagine. It takes a lot of energy, to be present at that level, right?
And the sessions are, like usually 3 hours plus, and it can be intense. It's really rewarding when you see like it pay off, but so I did seek it out though.
Wow.
Good for you. I worked there for a little bit while I was in grad school. But then it was just, I needed to more so focus on grad school. And then I just drove Uber and Lyft on the side just to make some cash. It was a little less taxing.
Yes. But it sounds like even your clinical experience right out of grad school, I mean, it was very targeted.
Grad school for looking for OCD.
Experience. Yeah.
So. Definitely. No, I knew, I basically a lot of the places I worked at for my associateship post-grad, getting my hours, most of it was, okay, I need to find a place that I can actually learn OCD and anxiety. And,
what was the name of that again? Just for everyone who's listening, where you worked prior to your private practice?
Yeah, it's called Renewed Freedom Center. So they're in West Los Angeles. They have a big specialty in kids, but work with all ages as well.
Good to know.
Yeah.
I'm trying to make mental notes of that because a lot of times I'm working with clients who probably would meet criteria for OCD, but it's not always clear where to send them. So
sure. Yeah. Another reason I like to, do this and all that. And then what was I going to say? Another really good resource is going to the International OCD Foundation. IOCDF's a website because you can find clinicians who do specialize in it and have training and stuff.
Good to know. Thank you.
So you just put in your zip
International
code.
OCD Foundation.
Yes, IOCDF.org.
Excellent. Thank you for that. Appreciate it. See, that's why I asked you on. I know you're a wealth of information.
I know you want actionable
Yes, I'm all
things and
about the
whatnot for your
tangible. Yeah.
listeners. Yes, yes, yeah.
Because you don't know what you don't know. I mean, even as therapists, like you were just talking about myself, like you get into this field and it's very, it's very specific. You work a particular job, clinic, discipline, but there's all of these other avenues and roads that we don't know about. I'm constantly learning about how things work, even with insurance and how to refer someone with Medi-Cal versus private insurance, and what type of therapist or what type of clinic or what's available, or even career wise, as a therapist, what are your options? What can you do? What, outside of the typical box that we understand. So
Yeah. No, it's constantly growing, constantly learning. I mean, you kind of telling me all the places that you currently work and, doing
Mhm.
those, assessments for inmates and Department of Mental Health and all of that kind of stuff too. There's so many
Yeah,
different avenues that you can take. And then things
absolutely.
like this,
Yeah. Yeah.
and
Right.
podcasts and
Absolutely. Something more altruistic and yeah, giving back. Yeah,
totally, totally.
absolutely. So, good catch by your therapist, by the way, who's, referred you and to be assessed. I know it's not always clear, and that's why, what I hope to dive into is, it's not always clear when you're treating somebody with anxiety how
Mhm.
to diagnose for or look for OCD versus something ancillary, right? General anxiety, panic disorder, something like agoraphobia,
Sure.
trauma, PTSD, OCPD. There's a lot of meshment sometimes in symptomology that,
Hmm.
when we're trying to do a differential diagnosis or get an idea, clinical impression of what's going on, it's not always clear, you know,
Hmm.
what to hone in on and refer out for. And so,
Absolutely. Absolutely. Yeah. I mean, the assessment process, doing a thorough intake and really knowing the questions to ask and, gathering all the necessary information is crucial. You don't want to I always like to refer it back to like actual like physical medical treatment. You want to actually figure out like, okay, is the person dealing with a tumor? Is the person
mhm,
dealing with diabetes? Because the treatment's going to be very different regard, what it's going to
mhm,
be. um, Now I will say caveat of that though is with the good news here, I guess, is with the diagnosis of OCD versus anxiety, generalized anxiety disorder, or separation anxiety, or agoraphobia, the treatment's going to look relatively similar in the
mhm,
fact that exposure and response prevention, you're going to be actively facing these fears, while the response prevention part is, doing your best not to engage in those. We call them compulsions in OCD,
mhm,
or safety behaviors in
mhm,
anxiety, things that, give you short-term relief, but just kind of
mhm,
fuel the anxiety. So there's going to be an ERP component. Now, when you're doing a differential, I start all my patients out with a 90-minute intake session where I send over a lot of different assessments to, the
mhm.
Y box included, along with like, what's the Beck anxiety inventory. Um, there's one called the acronym is SCARED. I think it's like
Oh
screen for
yes, yes.
childhood
I haven't heard
anxiety
that one
and
in a while.
related.
Yeah.
Yeah. Yeah. Those kinds of different things that screen for all these different types of anxiety disorders. And what helps me is kind of figuring out what are the actual like content of the things that they're worried about. So, for example, in generalized anxiety disorder, you might see someone excessively worried about. There's a reason it's called generalized, because it typically your day to day things. So, work, school, family, finances, those kind of stressors that fall underneath generalized anxiety disorder. And with generalized anxiety disorder, too, you're not necessarily seeing somebody with OCD is going to be doing more like, not necessarily, but you will see more, I guess, ritualized behavior or like concrete responses to specific fears. So I'll give an example. Like, say someone with OCD has, an intrusive thought that they're really scared that they're going to lose control and hurt someone.
Mhm,
So, a response to that might be, okay, I have to seek reassurance from my parents that I'm a good person and not a bad
Mm-hmm.
person. There's like a direct correlation to that specific fear. With generalized anxiety disorder, a lot of times there's just kind of a lot of worry or rumination going on. I like to think of rumination basically as this mental process where you are putting on a detective cap and trying
Mm-hmm.
to figure out everything. So anxiety and OCD are fueled by uncertainty. We want to be 100% certain that whatever it is we're scared about isn't going to happen. So say, generalized anxiety, maybe you're really scared that, you're not going to be financially secure. So you're constantly worrying, trying to figure out, okay, if I budget like this, if I budget like this, if I do this, if I save here, all that kind of stuff. And it's constant, it's excessive,
Mm-hmm.
right? Because another important factor in this is you can't really diagnose something unless it's causing actual impairment in someone,
Right.
in the excessive nature. Because like anxiety is a totally normal and healthy emotion.
Absolutely. It's a prime emotion. We all have it.
Yeah.
It's
Keeps
healthy
us
to a large
alive.
extent.
Yeah, it
Yes.
keeps us alive. It keeps us safe. All those kinds of
Motivated.
things. And
Yeah.
motivated. Exactly. And on top of that, it's normal to a certain extent to kind of plan and problem solve, right? And make concrete plans for things, and that's fine. The issue though is when you have that plan and then you start doubting it or starting to try to refigure it out and kind of continue to go down that mental rabbit hole. But I got a little off topic. My apologies.
No, it's perfectly on topic. Exactly what I was looking for. Yeah.
With generalized anxiety, you might see like those worries as work, school, family, friends. If you're looking at social anxiety, like you said, there's typically two main fears I'm looking for. It's this, excessive worry that you are being negatively perceived. And then two, it feels as if there's constantly eyes on you and they're negatively appraising you, right? So you kind of just constantly worried about how you're coming off. What if I embarrass myself? What if I don't perform up to a certain standard? What if I say something stupid? All those kinds of things. And the behaviors you'll typically see in social anxiety in response is a lot of avoidance of social situations. And then if you do have to go to social situations, very much in your head, how does my voice sound? Am I standing weird? Am I, what's going on? Does my facial expressions match? Am I interesting enough? All these kinds of things you're trying to figure out. So a lot of ruminating going on there too. So when it comes to OCD specifically, like the content, basically, let me define OCD real quick, just for the listeners.
Yeah, appreciate
it stands for Obsessive Compulsive Disorder. So there's two components to it. You have obsessions and compulsions. So obsessions you can think of as any sort of unwanted, intrusive thought, feeling, sensation, urge that pops into your head against your will. It can also be in the form of an image or like a video playing on loop. And it's really just it's really distressing. Okay, these thoughts are thoughts that you do not want to be having. There are terms that I teach my patients called ego dystonic and ego syntonic. I don't know if you're familiar with those. Okay, so for the listeners, basically what ego dystonic means is these are thoughts that are not in line with your morals and values and who you are as a person. And OCD thoughts are ego dystonic, and that's what makes them so scary. Okay. And then ego syntonic are thoughts and things like that are in line with our values, what we like. So an example I like to use is, I have two dogs that I absolutely love and a wife that I love. And, I don't have harm OCD, but somebody, with harm OCD would potentially experience thoughts of, stabbing their dog or strangling their dog. And what OCD does and why it's such a bully and just a really, really difficult thing to deal with is it attacks the things you love and it knows what's going to get under your skin. So, little self-disclosure here. Like I have what's called also relationship OCD. You call it that. These aren't actual diagnoses. There's just like OCD is OCD.
Way to frame it.
We frame it in like, what are the content of your obsessions about? So, relationship OCD, like worrying about, the goodness of one's relationship, the goodness of fit, and if it's a healthy relationship, all these things, which again, totally normal to do. it's the excessive nature of it though, the constant worry. And so like all, intrusive thoughts about, how do you know you love your wife? How do you know this? Are you attracted to her enough? All these kinds of thoughts that pop in, and they are very distressing, right? That they're not in line with what I actually believe. So obsessions can be about anything that's going to get the sufferer's attention. If you're a new parent and you love your child and you have OCD, there's a good chance you're going to maybe have some harm thoughts of, oh my God, what if I just drop them on their head? Oh my God, what if I go crazy and I stab them or something, or drown them? And these people do not want this at all. The farthest from that.
Right.
So naturally, these obsessions that cause so much distress lead us to engage in compulsions. Compulsions are any sort of behavior that one does to get rid of the distress that are caused by the obsessions. And compulsions can be either physical, so things you can see, or mental, so things that appear. And in my personal experience, I had more mental compulsions. Yeah, there were some physical, but mainly mental. So concrete examples that, we'll use some of the, I guess what people probably know about OCD is like contamination fears, germs, right? Because that is a real thing with OCD that happens.
COVID didn't help any.
Sorry?
COVID didn't help any.
Oh, no, definitely not. So, what happens is, say I touch my computer and I have an intrusive thought of like, oh my God, there can be some sort of contaminant on that's going to get you really sick, and you might spread it to someone. So that obsession is going to create anxiety and that fight or flight response in me. And, it's very uncomfortable. So naturally, to make myself feel better, I would go either put some sanitizer on my hands or go wash my hands. The problem with that though is, say I wash my hands and then I immediately turn the sink off. And I have a thought of, oh my God, I just touched the sink handle after washing my hands. That's dirty. So I got to, rewash, all that kind of stuff. Okay. I got a paper towel. I'm going to turn it off like this. All right, cool. Oh, wait, I just opened the bathroom door with, and then you have to go wash again. And you get into this vicious OCD cycle. These compulsions are basically, you can think of them like behaviors that we do to get 100% certainty that whatever we're scared of isn't going to happen. So with contamination fears, I want to be 100% certain that, I'm not going to get sick. With harm OCD fears, 100% certain that I'm not going to hurt someone. With, and there's more quote unquote taboo fears, and there's something called POCD or pedophilia OCD, these intrusive thoughts. Yeah, absolutely. And it's really common. I wouldn't say, it's very common. And these people are the farthest from that, so these are really, really scary, debilitating thoughts. I would say the contamination, the harm, the sexual intrusive thoughts. There's also what we call just right OCD or just so OCD. Things need to feel a certain way or symmetrical or be, if something feels off, you just can't really go on.
It's like what you see in the movies where everything has to be aligned on the table, and the pen can't be like crooked, right? Everything's got to be
to a certain extent. Yeah, just right. Yeah. Like something that I dealt with as well was, more of that just right OCD with like, sometimes I would get stuck like working out in the gym because I would be doing, say, like dumbbell bench press or something. And you would be, say I did like 10 of them. And then if I got to that 10th one and like my left arm didn't feel just as even as my right, I would sit there and like kind of have to adjust until it felt right. And that would leave me in there for a lot longer than I really needed to be. That wasn't like a very, very severe one, but I definitely experienced more severe just right things, like with like bathroom routines and being in there for like hours doing things until it would feel just right. So basically with the obsessions, anything under the sun really is grounds for an obsession, as long as it's going to get the sufferer's attention and get them trapped in this vicious OCD cycle of having an obsession, becoming anxious, you do a compulsion, you get this temporary relief, but the obsession comes back and you just go around and around and around. So
that's a great explanation. That's like
thank you.
spot on. That's great. I've always thought of anxiety in general as being like the fear of pending issues or ambiguous issues that have no particular resolution because they're not immediately relevant, right? Or fear-based, right? We all think
absolutely
of anxiety as fear-based. So OCD then is, like you said, it's almost this vicious thing where it feeds on your desire to be protective of yourself and others or the things you care about. And then it's almost this overcompensation to make sure those things don't happen.
Exactly. I think that's really well put. And what was I going to say? And when I talked about earlier, the differential diagnosis, it's important. However, it's not like the end of the world in terms of treatment outcomes, because if you're doing exposure and response prevention and this treatment and stuff, you're going to be, because the anxiety vicious cycle and the OCD vicious cycle is the same thing. So social anxiety, for example, you have this fear of a social situation, so you have this emotional response, this anxiety, and then to get rid of that anxiety, you'll do something about it, right? A safety behavior or a compulsion, they serve the same function. So say you avoid the social situation, and then you get this temporary relief. But what happens the next time you have to go to a social situation? It's like this thought, this worry is going to come back, this emotion is going to happen, and you're just in the same cycle. You're having these uncomfortable thoughts that are triggering uncomfortable feelings, so you're doing something about it to get this temporary relief, and then the fear comes back every single time.
Absolutely. And working with clients with panic disorder, agoraphobia, I know something that I often lean on is the habituation hierarchy, exposure therapy, right?
Exactly.
Reduce the compensatory behavior, protective behavior, the safe behavior, whatever we want to call it, is basically to increase the distress tolerance, the threshold between the trigger and the impulse, right? To evade, to run away, to minimize.
Absolutely. Yeah. Do you want me to talk a little bit about
that'd be great.
Part of it?
Please. Yeah. Thank you.
So basically, before talking about exposure and response prevention, it's really important to just understand anxiety and it's the mechanisms and everything behind it, because like we were saying earlier, anxiety is a totally normal, healthy emotion to have, and it keeps us alive. I always talk with my patients about the idea of the caveman leaving a cave and seeing a saber-toothed tiger.
Not a good day.
The good old days. Yeah, so walking out of the caveman sees a saber-toothed tiger. If we didn't have anxiety or fear, that caveman might be like, "Oh my God, that is so cute. I want to go pet that." And what would happen to the caveman?
Would be a caveman very much longer.
No, he'd be dinner or whatever, right? And we would have never evolved to where we would have today, if we didn't have anxiety. So luckily, we do have anxiety. And I love saying, because like I work a lot too with like kids sometimes. So I'll say like, even like your dog has anxiety, your cat has anxiety, your bunny, all these, they all have this fight or flight response in them to keep them alive, So what happens is, that caveman sees that saber-toothed tiger, he feels that emotion, that anxiety, and his body automatically goes into the fight or flight or freeze response. And I know there's some more aspects to it, but just for simplicity purposes, the fight or flight response is basically our body is automatic response to whenever we perceive danger. And the key word here is perceive danger. Okay. And this is actually where anxiety disorders and OCD come into play, because sometimes our body will be perceiving danger when there is none, right? There's no imminent threat. So a whole bunch of things happen to our body when we go into this fight or flight response. Our heart rate increases. We need to have more blood throughout our body to our arms and legs to fight or run away from the danger. Our breathing will increase. A lot of times we'll feel this shortness of breath, or like we need to hyperventilate because we need more oxygen in our blood to get us to fight or run away. It's like our body's fuel, really. Also times our digestion will shut down. We don't need to be digesting food in the
Right.
presence of a
Not top
saber-toothed
priority.
tiger.
Yeah.
And not top priority, right? The energy is basically diverted from our digestive tract to our arms and legs to fight or run away, and that's great in those actual moments of danger. But when you're dealing with an anxiety disorder or OCD, when you're constantly going in and out of this fight or flight response and your digestion is constantly turning on and off, this can wreak havoc on your GI tract. So it's so common for people with OCD or an anxiety disorder, myself included, to deal with a lot of GI issues like constipation, digestion, indigestion, diarrhea, nauseousness, acid reflux. All these kinds of things are really common with the fight or flight response.
That makes total sense.
Yeah. So, and then one last takeaway too with this fight or flight response, basically our ability to think rationally or logically, that all happens in the top part of our brain, the prefrontal cortex, and that uses by far the most energy out of any part of our body. We don't necessarily need all of that brain power in the presence of an actual danger. So for an example, if a saber-toothed tiger, Patrick, walked into your office right now, besides being like, whoa, I thought you were extinct. What would happen if you sat there and you're like, that's dangerous. What do you think the best tool to use right now would be, or the best escape route? What do you think would happen in the time you actually decide that?
I would be gone. Yeah.
You would be gone. Yeah. So what do you actually think? She'd be a widow. Yeah, exactly. Right. So what do you think would actually happen? Would you
I would
freak
point out the window to my left?
Exactly. Yeah. Right. Automatically, like no thought happens. So what happens is when we're in this fight or flight response is the top part of our brain basically, I wouldn't say shuts off, but the energy is directed to our caveman brain, the part of your brain where you hear a loud bang and you jolt, right? What that means is our ability to think rationally and logically while we're actually in this fight or flight response is greatly impaired. So you with your social anxiety kind of related stuff, how many times, after the fact have you been like, oh my God, like, why was I anxious about that? That was just, there was really no reason to be, right? But then in the moment, the next time a trigger comes around, are you able to like actually think your way out of that or talk your way out of that? Or does it feel so real?
Yeah,
so
no,
scary?
Absolutely. Yeah, you learn, live and you learn. Yeah,
exactly. But we can't think our way out of anxiety. We can't logic our way out of anxiety when we're in this because that part of the brain isn't working. So we have to behave our way out of anxiety. And this is where exposure therapy comes into play because basically what happens when we have an anxiety disorder or OCD is this fight or flight response, this body's fire alarm is misfiring. It's going off when there's not actually danger. Okay. And every single time you're triggered and you do a compulsion or a safety behavior, you're just reinforcing in your brain that thing is actually dangerous and that is actually a bad thing. So let's use an intrusive thought, for an example, with OCD. Say you have an intrusive thought that you want to punch your best friend in the face, right? If you kind of just let that thought be there and let it pass, it's not really going to bother you. However, if that thought pops up and you're like, oh my God, do I really want to do that? Hey, John, I just had a thought of punching you in the face. Do you think I'm actually going to do that? And they're like, no, you're not. Okay, I feel better. Okay, cool. That just kind of reinforces that thought's actually dangerous and something to be scared of. So, and our bodies we are designed for survival. So we're constantly looking out for threats in our and if we respond to certain things like they're threats, they're going to keep popping up. So
makes sense.
Yeah, one thing I want to note too is intrusive thoughts are totally normal. Every human experiences them.
Thank you for saying that because I was like, yeah. Normalize that. Yeah.
Yeah, no, and I wish I said that earlier, honestly, because intrusive thoughts are a human experience. Like, I imagine you drive, right? Yeah, have you ever been driving down the road and there's a group of bicyclists to your right? And you're just like, what if I just mow them down? Or, you're driving down a canyon, you're like, what if I just drove off? Now, I don't know if you have harm OCD or not, but you might. But when you have those thoughts, are you like, what do you do? I guess. Yeah. What are you doing?
Okay. So like if I'm driving on the 101, like going on the coast or something, like, oh, wow, the ocean's like right over that cliff. Like, what if I accidentally jerked and, drove on, like you said, my first impulse is like to move to the left, you know, to
Move
do
to the left
something
a little
to
bit.
remove myself from the possible danger I just identified. Right.
Sure.
Yeah.
And
Drive a
then
little more carefully.
oh, sorry, go ahead.
I'll say just drive a little more carefully, or I might think like, oh, I have really precious cargo, you know, especially after becoming a father. It's like all of a sudden, like, oh, I start driving more carefully because I'm more aware of the risk around me or the level of responsibility on me to protect those I love. Right. And that's a
Totally.
form.
Absolutely. I'm sorry.
That can be its own form of anxiety, right? Parental
Totally.
anxiety. Yeah.
Absolutely. We could do a whole other talk on that,
Yeah.
I'm sure, another time. But so basically but then let me ask you this, like after you have that thought, are you constantly learning about that and thinking
No,
about all those things,
less of like
all
half
the
a
different
second.
possible,
It's over
right?
with.
Half a second, it's gone, right? That is your typical intrusive experience. Okay. When someone has OCD, they'll have that thought, be like, oh my God, why did I just have that thought? Wait, do I actually want to die? Oh my God, do I want my kids to die? Am I a horrible parent? And then you start kind of going down this rabbit hole that sucks you in. And, it's really interesting about OCD is people with OCD have intrusive thoughts and respond to them completely normally. So, like have someone, as long as it's not something the OCD latches onto.
Mm.
So, like,
Well,
for
that's
example, I have OCD, right? But I've really rarely had the experience of when I'm driving down a canyon. Like, I've had the intrusive thoughts of that, totally.
Mm-hmm.
But I've never gotten in that cycle of like, oh my God, do I actually want to do this? Does that mean
Mm-hmm.
what does this mean about me and all that kind of stuff?
Mm-hmm.
So it really only latches onto whatever the sufferer's brain will allow it to, I guess, if you will.
What we give meaning to, it sounds like.
Yes, because it attacks the things you care about most, values, all of that kind of stuff. So that being said, a fight or flight response, okay, it's going off when it doesn't need to be going off. We need to rewire that, okay? Now, the fight or flight response is a fun little fact for the listeners. If we're triggered and we do absolutely nothing, we kind of just sit there with the anxiety. The longest our fight or flight response can last is up to 60 to 90 minutes. After that, our parasympathetic nervous system kicks in and calms itself down naturally without doing anything. It's pretty remarkable.
Wow.
Actually.
That's fantastic. That's great news.
Yeah. It's great news. Great news.
Right.
Now, I could probably almost guarantee that people who suffer with OCD or anxiety disorder haven't really waited that long before performing their compulsions because the distress feels so scary. So you've never gotten to experience that. We call it habituation, the anxiety naturally going down, right? So with treatment, exposure and response prevention, this vicious cycle is happening with OCD. You're having an intrusive thought and you're having this uncomfortable feeling, this emotion, and you're doing a compulsion that gives you short-term relief, right? Problem with that relief is it's very short-term because it only lasts as long until you have another obsession. And what we know is we actually can't control, when I say we, just humans in general, can't control the thoughts that pop into our head. So you can't, I always like to use the example of don't think about a yellow duck. What are you immediately going to think about? A yellow duck, right? So don't think about hurting someone. Don't think about something bad happening. You're going to keep thinking about it, right? And then another piece of this is we actually can't control the feelings we experience either, right? So if I always say to my patients like, oh, stop feeling anxious. Is it possible? No. If it was, we wouldn't need therapy.
Right.
Or therapy really wouldn't be a thing. Yeah. But the only thing we actually have direct control over is our behaviors, what we do, the compulsions, right? Our response to those thoughts and feelings. And the good news is changing your behaviors indirectly changes your thoughts and feelings. It's called the cognitive triangle in CBT, or thoughts, feelings, and behaviors, right? So exposure and response prevention, what we're going to do is we're going to intentionally trigger those obsessions, those worries, those anxieties, those fears. And instead of doing our normal responses, which is those compulsions, to get that quick relief, we're going to wait it out. And like I said, that's 60 to 90 minutes. A lot of times it's less, just depending on the severity of the trigger, will pass. And what you'll experience is this anxiety will naturally go down. And you can't just do it one time. You have to repeatedly do these exposures. It's because ultimately this treatment is very behavioral. I like to compare it to, like, say you're learning an instrument. If you practice one time a week, you're really not going to get where you need to be. You have to practice every single day for a good amount of time for that learning to take place. Because when you do that exposure again and again and again, and you're realizing, okay, I'm fine, I can handle this, that fight or flight response stops going off so much. And if it does go off, you inherently are like, oh, yeah, there's that OCD again. There's that anxiety again. And you actually start to learn and build insight more so too into that anxiety and OCD. So these exposing yourself to these triggers and then, really working hard not to do the compulsions is ultimately what's going to get you long-term relief from OCD as well as anxiety disorders. And this is done in a very gradual process, in treatment with myself. We start out by basically naming this monster, this OCD anxiety monster, because it is a bully, right? It's a bully that comes in and takes over your life and makes you, shrinks your world, right? And we need to treat it as a bully. And so then after that, we create what's called this monster's rules list, which is a list of all of the compulsions or safety behaviors that one does to get that short-term relief. And then we rank on a scale of 1 to 10 how anxious you would be breaking those rules and not doing those certain compulsions. And that's basically how we create what's called an exposure hierarchy. We start by exposing you to semi-triggering triggers, so that you can learn what you said earlier, distress tolerance, your ability to handle uncomfortable feelings. And the better you get at that, the easier it is. I don't say easier. Easier is not the right word because this treatment ain't easy. No. Definitely not.
Potentially uncomfortable.
Yeah. It's not easy, but it is very effective. That being said, you build more distress tolerance, and then you also learn through, because that's what habituation means is learning. You're literally getting used to, you're learning that you can handle whatever uncomfortable feeling arises, whatever thought arises. And you basically learn that, okay, it really is just a thought, or okay, it really is just a feeling. I don't have to do anything about it. So that's the majority of treatment, is very behavioral. I also incorporate a lot of mindfulness components to treatment, teaching a lot of mindfulness to be fully present in the exposures, and acceptance of, all thoughts, feelings, physical sensations, because I always like to say, like, if you resist it, it's going to persist. So, like, especially with, like, say, panic disorder.
That's a great point to make. So we want to make sure that in the process of doing this habituation work, that the individual is fully attached. They're not, or associated, I should say. Because just
in the moment as much as possible,
but not emotionally, mentally present. They could be detaching, right?
Right, and we don't want that necessarily.
Associated, yeah.
Right, because that again, that is an avoidance of uncomfortable feelings, and again, going to reinforce that something bad can't handle it. And I'm trying to think. I mean, there's a lot more I could talk about with it, but I think that's kind of the general gist of treatment. Do you have any specific questions?
That's fantastic. Thank you so much for talking around what OCD is, what it looks like, the life applications. I really, really appreciate that. I know everybody watching and listening does as well. And then how that might walk and talk a little different from your general anxiety and other forms of anxiety, and what the course of action is for OCD in particular, and how that works. And I really, really love the analogies of the monster, the bully, right? Because that makes a whole lot of sense. And I think for anyone struggling with that type of anxiety disorder, that it would be reassuring to understand that, this is not obviously what you really want to happen, and this is treatable, right?
Very treatable. Yeah, it's very treatable. And another reason I'm so passionate is because I think there's such a misunderstanding of OCD. It can take an average of 14 to 17 years to be correctly diagnosed and treated, because it's just so misunderstood. So, anything we can do to lower that amount of time. But thanks. Is there more? Or are we?
No, I mean, that's perfect. That's perfect. Yeah. And so the specific treatment you were talking about is,
exposure and response prevention.
Thank you. Exposure and response prevention. The response being that compensatory behavior. We're trying to prevent that, right?
Exactly. You expose to the trigger, you prevent the compulsion. So you can
just try to make sure we all understand that. So if anyone's looking for treatment, they know what to look for. A therapist who is trained in that type of model, right? Or intervention.
And don't, just for consumers, ask as many questions as you can about the therapist's experience. If they're giving you kind of broad, not as specific as you'd like, those kind of would be some red flags. You want someone who, you feel really comfortable with and feel really, just that's like any other therapy, just someone you feel who really understands you, gets you. But, I think too many people have been through not great experiences with ERP and things like that. A big part of it due to lack of competence on some certain clinicians. And, I think that's just, it's so be a, what's the word? Aware consumer. I don't know if that's the right word.
Yeah. Don't be afraid to shop around, right? Don't be afraid to.
Yes. Yeah.
Advocate for yourself. Yeah.
That's the word I was looking for. Thank you.
Yeah, absolutely. Great advice. So obviously I want to have you back on in the future if you don't mind.
Yeah.
Your wealth of information.
There's a lot more we can dive into. Like we can talk about specific exposures. We can talk about, other anxiety disorders and how to treat those, and interoceptive exposures for panic disorder. So many, it's just a lot of things.
Yes, I know it's a deep well. So
yeah,
I know we just scratched the surface of it, but you did a great job explaining, what the definition of OCD is and what it looks like, how it's treated. And I'm sure this is going to be very beneficial to our audience. I appreciate it.
Thank you so much for having me.
Yeah. Where can we learn more about you and the work you're doing?
Yeah. So you can, my website is Cohen OCD Therapy. So Cohen is COHEN.com. So CohenOCDtherapy.com. And, my contact info is on there. If you are, wanting to become a patient, reach out. I will get in contact with you relatively quickly. I don't like to leave people, with messages for days and days. So I do my best to return calls as promptly as possible, and emails as well. And you can email me at andrew@CohenOCDtherapy.com. Oh, yes, there's my website.
This is your site, right?
That is my site, correct.
Perfect. So, thank you.
Yeah, that phone number. And then you can get contact. I'll get my email.
Contact up here. Phone number. Nice.
Yeah. And
you offer telehealth. That's good.
Offers telehealth. Yes.
Awesome. Nice.
And there's me.
All right.
I love it. Yeah. And then I'm trying to think. Oh, and then just for, really good, the iocdf.org as well as ocdsocal.org are really good resources for people suffering with OCD. But I think you could put those in the
show notes and everything. Yeah, absolutely. Yeah. These are all your socials down here, right?
Correct. Yes.
Good stuff. I'll be sure to link up to that.
Perfect.
All right. Hey, you're using Simple Practice for your website.
I am. Yeah.
Lots of good things.
Do you use Simple Practice? Yeah, no.
I don't. Really I bootstrapped off of WordPress, but
okay.
I was just out for the challenge, I guess. But
yeah, no, it's fair. Fair.
Yeah, I've heard lots of good thing about Simple Practice though with their websites.
It is really good. It's good EHR.
Nice. Yeah, it's an all-in-one, right? It's great.
All-in-one.
I use Therapy Notes for mine, but they don't include a website.
No, I don't. The Renewed Freedom Center, when I was there, at least was using Therapy Notes. It's good too. I like it. I think Simple Practice is a more friendly interface, user-friendly interface.
Good to know.
Yeah. I don't work for Simple Practice, by the way. So
yeah, awesome.
I'm not just plugging Simple Practice, but yeah, I don't work.
Of course. Excellent. Well, I really, really appreciate you being on. I love the work you're doing. It's very, very much needed aspect of the profession. So keep it up, and I will be tapping on your shoulder to have you back on if you don't mind.
Please, I would, love to come back and, talk about a lot of other things.
Excellent. I appreciate it. You enjoy this more mild Southern California day? It's not 100 degrees right now. So good day for a walk.
So much better. So much better.
Looking forward to the fall.
Yeah.
I know we share the
absolutely.
same weather here. So LA area.
Yes, definitely.
Okay, right. Andrew. Well, thank you so much. And I hope you have a great week. Okay.
You too. Thank you.
All right.
Bye.
Take care. Bye-bye. Hey, if you're getting value from this content and you haven't done so already, please be sure to like and subscribe to the YouTube channel and podcast to help raise mental health awareness, and be sure to share with family and friends. And if you happen to be a podcast addict like me and listening to this on Apple Podcasts, if I could please have you share your appreciation by taking 2 minutes to leave a review, that will help push this podcast out and raise more mental health awareness. Thank you so much for your time. I hope this was valuable and another tool for your toolbox. So until next time, keep making good things happen. Bye-bye now.